king procedures of the gastroenterology. Whatever we have, ERCP still is one of the important. You have to have at least quality measures. You have to perform the procedures with good standard technique and also advanced technique. Then I'll talk about when you have to use a mechanical lithotripsy, definition of difficult stone, not large stone. Most of us today say large stone, no, this is incomplete definitions. Role of cholangioscopy in those cases, and the future of radiation-free procedures, and the end I will conclude with a few slides and summarize my talk. So before we start, this is the Arabic Society of Gastrointestinal Endoscopy, was created last year. They pushed me to be a president with the very difficult resistance, and my colleague Dr. Ahmad, he is the vice president of the society. So we are very happy in the future to have a good collaborations. I think you will hear a lot of investment in this society to promote training and also education, okay? This is the, Dr. Reddy was launched with the asde Society, Hassan Cesar in our life endoscopy, and also Muhammad Haddad from States, and also Dr. Dua. Again, society to have a good future, we need your support. So now, if you go back to the ERCP, so everybody have a standard ERCP technique. First, you have to do a sphincterotomy, and then followed by stone extractions, either using the balloon or using the baskets. But still, we have some of difficulties. So 10 to 15% of those stones usually very difficult. So I will go to step by step now. What you have to do first, you have to do very good sphincterotomy. So the sphincterotomy depends on the size of the stones, and also it's simple or difficult. If you have a stone can be removed by only sphincterotomy, so you have to perform good sphincterotomy. So either you have to do it or don't do it. Okay, you have to do complete sphincterotomy or don't do it if you think if you can do and remove the stone in the same time. Then next step, there is a debate between using baskets or balloon. So both of them, they are equal, and you can choose what you prefer, but most of the new generations now, they're using the balloon. Why? Technically very easy for the endoscopist and also for the assessment. So you have to have the baskets, and usually this is not mechanical lithotripsy, very simple baskets. You grasp very small stones, less than 2 centimeters or maybe sometimes 1.5 centimeter to be removed by the baskets. Either can be guided, wire guided, or without any wire. So it depends on the manufacturers or the type of the baskets. So I prefer to have another modalities, balloon extractions. So using the balloon, size of the balloon, usually from 9 millimeters, 11.5, and 13 or 15 millimeters. So it depends on the size of the bile duct. You can use what you prefer. The easy is the balloon to be removed, and then most of the time, if you have a good sphincterotomy and you're having basket and balloon, you remove the stones. If you have very difficult, and then you see the CBD is dilated and the distal bile duct is not dilated, you can do biliary sphincteroplasty. Using the CRE balloon. CRE balloon is control radial expansion. Control radial expansion, so you can dilate the orifice, but you have to choose the size of the balloon based on the size of the bile duct. So don't have oversize, or sometimes you have a bit less size to be in the safe side. Most of the literatures and the experts, they prefer not dilated more than 15 millimeters. So you can choose 10, 12, and 15. Once you have a good dilatations and breaking all the muscles, it's easy, or the sphincters, it's easy to remove the stone. Complete sphincterotomy will not have enough effect like having some of the good dilatation using the balloon. Now when you have these modalities, you can remove up to 85% to 90% of the stones. Still, we have difficult to have some of the patients having different anatomy. This patient with a preambulary diverticulum, so you have limited to do extended centrotomy and very limited to do centroplasty. So it's easy to have cannulations, and this is one of the definition of difficult stone. Either you can have small stone can be removed, or maybe you think about using advanced technique like the cholangioscopy. So after the cannulations, you have to have at least very small sphincterotomy, and then you can try to remove the stone. If not, then you can set plastic stent and then rebook the patients if you have a plan to do cholangioscopy, or you can do the cholangioscopy at the same time. Now this is the principle of using the sphincteroplasty, not exceeding 15. Some of the experts, they said you can dilate up to 20, but please not exceeding more than 15 millimeter because you will be in the safe side, okay? And you have to approximate between the size of the bile duct to distal bile duct structures. Then it depends on the time of the balloon. There's no rule how many seconds you can wait. So some of them just dilate, break the muscles, and deflate. Some of the experts and the evidence, they say you have to wait up to 10 or maybe sometimes 2, 3 minutes, up to less than 5 or 3 minutes. Nobody can wait for 5 minutes to have dilatations, okay? Then avoiding any risk of dilating over the stone. You have to push the stone up. Then the risk of the perforation usually with the distal CBD structure. So if you have a stone with the distal CBD structures, so better to use other maneuver like cholangioscopy. As you see, this is some of the principle of the standard technique. Now, if you move to the mechanical lithotripsy, as you see, this is the very difficult to use sometimes, but you have to have both systems, either through the scope or outside the scope. You have to have standard RCP, you have the plastic, the basket inside, grasping the stone. But if you have the stone more than 3 centimeters or 2.5, I think the efficacy of the mechanical lithotripsy is very minimal. So more than 3 centimeters, you have to think about using the rule of the cholangioscopy. Then you have to take the scopes out. Then you have to insert the mechanical lithotripsy. It's outside handle. Then you have to go again by RCP to perform the standard technique like balloon and baskets, okay? And this is one of the cases you have to see as many stones in the CBD, you have to grasp the big one. If you fail, then you have to move the next step. Now, this is one of the techniques also for the mechanical lithotripsy. You have to have ERCP, you have to choose the mechanical lithotripsy basket. There's a specific basket for mechanical lithotripsy. Then if it's stuck there, you have to cut the sheet, then you get it out from the ERCP scope, and you take out your ERCP scope, and then you have to insert the mechanical lithotripsy is outside. At the end, usually it has some complication. This is the issue, and some of the company now, they produce through the scope mechanical lithotripsy, and easy to be controlled, and the complications is very less. Now we have to move to, now we have this is the standard for everybody. So 80%, 90% can be managed by most of the expert or general practice of gastroenterology doing ERCP. But it's still the difficult stones is not only the size. So we don't have ourselves to committed to the size, not only the size. You have a lot of definition of difficult stone. So this is the definition. This is one of the Japanese paper, 2013, give us the definitions of the difficult stones based on the anatomy and the characteristics of the stones, location of the stones, and patient condition. So if you have Alger's anatomy, like preambulary diverticulum, sometimes very difficult to apply all the standard. So indication of the cholangioscopy is there. If you have a large stones, and then more than 2.5, 3 centimeter, this is a difficult stone. If you have multiple stones, like each other, or extended to intrahepatic, this is a difficult stone. If you have a stone above the strictures, or maybe a Maritzi syndrome, usually it's difficult stone, or the patient have coagulopathy, you cannot do and perform complete sphincterotomy. So this is the difficult stone. So I will show you some of the big example. As you see, this is patient having some The multiple stone is very simple, this one. This is very complex inside the bile duct, is multiple and extended up here. This is also intrahepatic, so the all definitions of difficult stone. This one almost the same, this is the Merici syndrome as you see here. Another one is a complex, both CBD sold with the Merici syndrome. And now also this one, another Merici syndrome after prostatectomy. This very small stone, but down is very structured, so you cannot have dilatation because this bile duct is not dilated. So very difficult to perform these stones. So not only the size, is having some narrowing of this CBD. Preambulary diverticulum also is very good example to do cholangioscopy. As you see here, this is very big diverticulum. We try to get position of the ERCP. We're facing a lot of difficulty to have a complete sphincterotomy now. So this is a difficult stone. If you cannot remove it, then you have to move to very safe technique with cholangioscopy. This is almost the same principle. As you see the Merici syndrome, you know, now we're having also the laser lithotripsy can be managed those kind of stone and easy to be managed, and I will show you the paper at the end of this presentation. But we have tools after we filled all the standards. So cholangioscopy with the lithotripsy. Either you having laser or EHL. So both are very effective and they are similar and almost the efficacy is the same and they have some preference. So the AHL is very friendly to be used. It's very compact, small machine. You have very good setting. It's very easy to be used. The catheter is very big and good to be inserted through the ERCP. The laser is totally different. You have very protective. There's a lot of setting, very thin catheter, very thin fibers. So you have to be careful, and you can be used multiple times up to 20 procedures. EHL you can use only single use. That's why you can use 2 AHL Pro for one patient. Now, this is the dual system, so we have it in the markets. And then if you think about the spyglass, so the spyglass usually it's our maybe cholangioscopy. We have a lot of company now producing the cholangioscopy. So we have in Boston, we have Microtech, we have a lot of Chinese company producing the cholangioscopy. So it's easy to be used. And then it's almost single operator. You have to use it by yourself. No need to have somebody to help you. Using the shaft, the scope, easy to insert it or to correlate the biliary system of not dilated. And usually is having some of the technique and helping your patient to break down the stone. This is another one, is from the other company. This is Microtech also. Is the another cholangioscopy. It's a similar principle, easy to be used. If you have a very experience in inserting the basket stent and also controlling the ERCP, it's easy to control the cholangioscopy and also the scope. And at the end, you have to control it by yourself because it's easy to control the two scopes, either the cholangioscopy and or the duodenoscope. It's difficult to have somebody with you, and this is the benefit of using this kind of cholangioscopy. Now, if you think about the procedure, so we have EHL breaking the large stones, or EHL or laser. So what you prefer, what you have in your unit, so you have to use it. It's almost the same and very effective. As you see, this is the two procedures. One of them showing the very hard stone. As you see, very hard stone, I prefer to use laser usually because you have to use many probe for AHL. If you see the other video showing that the stone is very soft and you can use it, as you see, it's different type of a stone. So very easy to be break down by AHL. The other one, we spin 2 probe and then you have to use at the end laser. So it depends on the type of the stone. Sometimes you can tell what type of cholangioscopy can be used. This is one of the patients having very not suggestive good cholangiogram, but despite that, the patient having a lot of intrahepatic stone with a lot of pus inside. So we try to think how comes we cannot see the stones from initial RCP. So the cholangiogram usually is not that sensitive. It can tell you maybe there's 1 stone or 2, but this patient having a lot of stones and with a cholangitis, he presented to the hospital many times over the cholangitis. As you see, we are inside intrahepatic and we use the basket through this cholangioscopy and we removed it from the intrahepatic and easy to be removed, and then patient was stented and he required 2 cholangioscopy and the third one was completely clear. Merites also cannot be managed nowadays except by cholangioscopy and laser or lithotripsy. As you see, it's complete block of the stone in the cystic duct. So as you see I will show you some of the paper here. This one, I will skip this video. Again, this video also. So now you see the evidence of the comparing the endoscopic clearing of the cholangioscopy and mechanical lithotripsy is very clear here. It's 93% compared to 67% of those patients. And usually the side effect, the complication is almost similar. So we have to use your tool either to spend on the mechanical lithotripsy or go ahead and do cholangioscopy and you can finish your patient. This is another study comparing also the efficacy of the cholangioscopy compared to the large balloon dilatations. As you see, the efficacy is also 94% if you have balloon dilatation on our mechanical lithotripsy. So it's very effective compared to this procedure. As you see here, clearing the duct of large or difficult, very difficult stone is almost up to 91% with single session. But with a multiple session, for sure, 100% you can clear the intrahepatic stone or extrahepatic stone with the similar also side effect, and they are less almost adverse effect. One of the point here, you have to use more antibiotics because the cholangitis is more common with the cholangioscopy. If you see the Merici syndrome here is now, I think is a nightmare for the surgeon to do the Merici syndrome because they have a lot of leak, injury to the bile ducts. So the efficacy here of the cholangioscopy doing patient with the Merici syndrome is up to 94% with a single session. If you try to another one, so you will save your patient from a lot of complications, and then they can do the cholecystectomy later on without any adverse effect. And if you see also another comparing the mechanical lithotripsy to the cholangioscopy, as you see here is almost very clear, comparable, very good efficacy compared to the mechanical lithotripsy. And those who's failing mechanical lithotripsy, they are crossed over to the cholangioscopy and they have 100% removal and fragmenting the stone. This is our data. It was published. It's almost showing the same clearance up to 98% for all the stones. So we have a similar data to other international data. And now if you move to radiation-free cholangioscopy, I think this is not yet because still need a lot of ERCP, and you have to think about the cost of the cholangioscopy. If you do cholangioscopy without fluoroscopy, then the costs were very high, but they have good efficacy here and have very clinical success and technical success, but I think it's not yet implemented to our practice. And at the end of my talk, so we can have at least very good objective of the presentation. So most of us agree, more than 90% you can perform and you can remove the stone by standard technique. Good sphincterotomy with the baskets, with the balloon extractions, with the sphincteroplasty up to 15%, then mechanical lithotripsy, but then 10% and 15% of those patients, they are very difficult, so you have to refer it to the specialized center. Don't try to remove difficult stone and then you spend many times doing a lot of ERCP for your patient, 6 and 8 ERCP, a lot of plastic stents, and then a lot of cost. So one cholangioscopy is cost effective, better than doing for 6 ERCP for your patient. So this is one of the things when you have to send the patient to the specialized center. And then still we have to consider the cholangioscopy. I think it became one of the standard care in daily practice. And for the radiation-free ERCP, I think it's still costly. Not yet. We need a lot of evidence, and we have to have high skills endoscopists to perform ERCP without fluoroscopy. Surgical acceleration of CBD, I think now it will be less and less and less, and nobody can send a patient to the surgery nowadays with a presence of high technology of the cholangioscopy to be very effective for our patients. So at the end I'll finish. This is our pictures from live endoscopy in Saudi Arabia. We have it yearly, and this year will be in January. And this is also our colleagues, our hospital, King Fahd Medical City in Riyadh. And next live endoscopy will be in January 29 to 31, 2026. And I hope most of you guys, you can have a chance to visit us. And this is our YouTube channel for Saudi Life Endoscopy. You can see all the lectures, all the presentation there, and you see most of the expert people, they present their lectures, and also you see very high technique of life endoscopy. And thank you very much for listening.